Outreach team. Welcome to the behavioral support rounds. Today's topic is ADHD in older adults and relationships with neurodegenerative syndromes. So just a few things to cover first in terms of acknowledgement and land acknowledgement. Although we are meeting virtually, we acknowledge that Baycrest and our related Toronto Central Behavior Support Programs operates on the traditional territories of many Indigenous nations, which have cared for the land of for thousands of years, including the Anishinaabe, Haudenosaunee, and Huron-Wendat peoples. And we recognize the current treaty holders, the Mississaugas of the Credit First Nation. This land remains home to many diverse First Nations, Inuit, and Métis people, and is subject to the Dish with One Spoon Wampum, an agreement to peaceably share and care for the Great Lakes region. We are grateful to have the opportunity to work on this land today. You may live and work in different territories, so we encourage you to reflect on the land on which you are located and to consider your relationship to the land and to the people who are the traditional keepers of the land. A few housekeeping items. Again, if you can keep your microphone muted, so it should be automatic anyway. As you heard, today's session will be recorded. There will be opportunity for questions at the end that you'll be able to use the chat or Q&A section. If you have any difficulty with technical aspects of things, you'll see Telehealth Agnes is on today's session, and you can message her for support with that. At the end, if for those of you interested in receiving a certificate of attendance, please enter your name and email address in the completed evaluation form, so that will be sent automatically to you, and you'll make sure to receive a certification for today's session. So I'm happy to introduce our presenter today. She used to work at Baycrest and help support the BSO team many moons ago. So Dr. Brandy Callahan is an associate professor of psychology and Canada Research Chair at the University of Calgary. She holds a PhD in clinical neuropsychology from Université Laval and completed clinical and research fellowships at Baycrest and Sunnybrook Health Sciences Centers. Her research program integrates neuropsychology and physiological biomarkers to better understand age-related brain changes in adults and seniors with complex medical psychiatric histories. A major focus of this work is to determine mechanistic interactions between normal aging, ADHD, and neurodegenerative disease. So I'm going to pass it over to you, Brandy.
Thank you so much, Kara. I'm so pleased to be here. It's always nice to be invited to do these things for Baycrest people. So I'm going to share my screen and start my presentation. Okay, can everyone see that?
Yes, all good.
Awesome. Okay, wonderful. So thanks for that introduction. Today, as Kara said, I'm going to be talking about ADHD in older adults and relationships with neurodegenerative syndromes. Before we jump into it, I'm just going to say that my research program in general, my research studies are supported by grants from the Canadian Research Chairs Program, the CIHR, SSHRC, and the Alzheimer's Society of Alberta and Northwest Territories. What I'm going to be talking about today, like this program hasn't received any specific kind of support, and I don't have any conflicts of interest. And the information I'm going to be presenting today is evidence-based. So I'm going to start by sharing my take-home messages. I like to do this at the beginning just to sort of set everyone's expectations for where it is that I'm going with this talk. So the first thing that I hope you learn from this presentation today is that ADHD is common in older adults, probably more common than you think, even though people tend to still speak about ADHD as a disorder of childhood or of youth. I would like you also to take away from today's talk that ADHD may be associated with MCI-like cognitive impairment. And also, I'm going to present some emerging evidence suggesting that it may actually increase a person's risk for dementia as they age. So just because I know that this is a more sort of geriatric focused crowd, I'm just going to take a moment to talk about what it is ADHD, just to provide a little context here. So ADHD stands for Attention Deficit Hyperactivity Disorder. And as its name implies, it's associated sort of with two facets of issues. The first facet is a cognitive component, and in adults, that usually looks like problems concentrating, significant forgetfulness, maybe problems multitasking. And then the second piece of ADHD is the H, so the hyperactivity, which is the behavioral component. And so that refers to essentially problems regulating behavior and controlling impulsive behavior. So that might look like, acting without, thinking, or blurting out, parts of a conversation. I do want to take a minute here to just say that when I introduce ADHD to adults and I describe it this way, almost always people will say, well, that actually sounds a lot like me. I'm pretty forgetful. And sometimes I, blurt things out, and I don't always pay attention and have trouble multitasking. So I do want to take a second to just emphasize that ADHD symptoms are normally distributed within the population. So what I'm showing you here on the y-axis, the vertical axis, is the number of people in the population who endorse a certain number of ADHD symptoms. That's on the horizontal x-axis. And you can see, and in black and white is men and women. You can see from this very clearly that the vast majority of the general population endorses somewhere between, 4 and 12 ADHD symptoms. So it's totally normal to experience inattention and impulsivity and restlessness and things like that. But you'll notice that the tail end, so either tail end of this distribution, these symptoms are not endorsed by very many people. So almost nobody endorses no symptoms of ADHD, and very few people endorse lots of symptoms of ADHD. So what I'm going to be talking about today specifically is this segment of the population who are really at the sort of high tail end of this distribution, who are really endorsing, 15, 18, 20 symptoms of ADHD that are really disruptive to their life. And this shaded red area, that represents about 3% of the older adult population. So in addition to these cognitive and behavioral issues that are present with ADHD, the diagnostic criteria state that it also has to begin in early life. So by definition, ADHD is a neurodevelopmental disorder, meaning that it emerges in the early developmental period. That, I'm going to get back to this, but that can be a bit tricky to ascertain when you're speaking to someone who's in their, 70s, and you're trying to get a sense of like, when did these problems begin? It's often hard to get a specific age of onset exactly, but sometimes people will describe it themselves as, oh, I've always been this way, or this is just the way that I am. And in that way, the features of ADHD are sort of similar to long-standing personality traits. It can be helpful to think of them that way. ADHD is usually chronic, so it begins in early life, and in upwards of 60% of individuals, they will continue to live with ADHD into adulthood and old age. Although the type of problems, like the symptom profile, changes. So if you think of sort of the classic presentation of a child with ADHD, you might think of a very hyperactive kid, can't sit still, bouncing off the walls. That flavor changes as people get older. That hyperactivity piece tends, not always, but tends to fall away. And what's left that's usually quite problematic is the cognitive piece, so the inattention and the forgetfulness. The last piece that I want to emphasize is that ADHD is highly heritable. So it runs in families. There's estimates that 3 out of 4 children, so 75% of kids with ADHD have a relative with the same condition. And actually in adults, many times adults will become aware that they may have ADHD or seek help for ADHD after a younger person in their life is diagnosed. So a child or a grandchild, they'll sort of be going through the assessment process with their kid and realize like, this actually sounds a lot like me. And so the fact that it runs in families suggests that there's a strong genetic component. Okay, so why should we care about it in older adults? So it is relatively common. As I said, about 3% of older adults are in that really high symptom range. And although 3% may sound like a pretty small number, that actually works out to about 1 in 30. So think about the older adults that you see in a week in your line of work. There's a good chance that at least a handful of them will probably have ADHD, probably undiagnosed, because it's very often still now considered a disorder of childhood, of youth. And so, geriatricians and healthcare professionals working with older adults often don't think to look for it. And I'll revisit that. I think it's really important to care about it in older adults because it really can compromise and jeopardize their aging experience. So as a group, adults with ADHD have a significantly higher frequency of depression, anxiety, and social isolation than their neurotypical peers. So really are struggling socially and from a mental health perspective. ADHD also directly impacts financial stability in later life. And this is for a multitude of reasons. So first of all, people with ADHD tend to struggle in school, so don't have as high occupational attainment. But also one of the characteristics of ADHD is its impulsivity. So impulsive spending, for example, can lead to reduced income later in life and lower retirement funds. One thing I'm going to be focusing on today is their increased risk for medical problems. So again, as a group, adults with ADHD have higher frequencies of many important medical conditions that can impact their cognition in later life. So this is just one example of this, a relatively recent paper that had a really nice sort of comprehensive look at this. What I'm showing you here on the vertical y-axis is a person's odds of developing certain major medical conditions that are listed on the x-axis, the horizontal axis. And you can see here that the ADHD participants, these are the blue markers. Oh, I think I have a laser pointer actually. Here we go. The blue markers are people with ADHD, and you can see that they have 2 to 3-fold higher odds of developing all of or most of these medical conditions relative to the general population, which is the dotted line here. Just to highlight a few that are particularly relevant for cognition. Are diseases of the central nervous system. So this is like epilepsy or sleep disorders, respiratory conditions like COPD, musculoskeletal disorders, that's like chronic back pain, metabolic conditions like diabetes and obesity. Something I'm going to focus on in my talk today is disorders of the circulatory system, vascular conditions like hypertension, ischemic heart disease, AFib, stroke. So these are important to highlight because, as is probably common knowledge to most of the people in this talk today, these are things that can impact how a person ages cognitively, the extent to which they're able to contend with aging. Now, just for clarity here, this graph also has these green and red markers that designate siblings of people with ADHD, and siblings also seem to have higher risk of these conditions. So this is just sort of illustrating that genetic susceptibility for ADHD also plays a role in some of these associations. Okay. So one of the most important reasons to be aware of ADHD in older adults, in my opinion, as a geriatric neuropsychologist, is that its cognitive features can look like signs of early dementia. And that can be very confusing from a clinical standpoint. And so I just want to share a case in point here to sort of drive home the point I'm trying to make. What I'm about to show you is an excerpt of an email that I received completely out of the blue from a woman who I didn't know, but I guess this was about 7 years ago. She reached out to me just as I had joined the University of Calgary, and I guess she found my research profile online or something. Anyways, she reached out to me with this message. I'm the mother of 3 boys, and I've been diagnosed with anxiety and ADHD. 2 of my sons are currently on medication for ADHD, and my mother, who's 80, is suffering from MCI. Everyone assumes that she has Alzheimer's, but she has had no significant progression over the last few years, so she's not getting worse. Her doctor has treated her with donepezil, a cognitive enhancer, but again, there's been no significant change, so she's not getting better on donepezil. I'm convinced that there has to be some link between what I and my children have and what she has. Another link is that we all have restless leg syndrome, so that's a sleep disorder. I can't find a way to pursue this, and everyone thinks I'm crazy to suggest that my 80-year-old mother might have ADHD. The randomness and inability to organize are obvious traits that permeate our DNA. So this email really hit home for me. It really spoke to me because I received it at a time where I was really becoming very interested in this relationship between ADHD and aging and how ADHD might impact aging. And I feel that this woman's experience really illustrates how ADHD can mimic the presentation of dementia, in this case, Alzheimer's disease, to such an extent that her healthcare team has diagnosed her with Alzheimer's disease and has prescribed her a cognitive enhancer, right? And so the care team is not thinking to look for ADHD here. They're really thinking it's some sort of dementing syndrome, but she has lots of the risk factors for, or lots of the familial loading, I'll say, for ADHD, right? Her daughter has ADHD and 2 of her grandsons, and she's not getting worse, which you would expect to see if a person truly had progressive Alzheimer's disease. Now, the woman's email mentions a few other factors that really complicate the clinical picture. So she alludes to the fact that her sons, I think it's her sons and her, are medicated for anxiety. They all have restless leg syndrome. So comorbid mood, anxiety, and sleep disturbances are extremely common in ADHD. And as I'm sure many of you know, it's also extremely common in many early dementias. So on the one hand, you have these cognitive pieces, you have these behavioral pieces, you have the comorbid pieces that really create a very confusing, sort of muddy picture of what is going on in an older person who's having these issues, right? These shared phenotypic features across ADHD and sort of early MCI stage dementias, I will say, may be contributing to a rise in ADHD diagnoses in mid to late life. So we're seeing significantly more middle-aged and older adults getting diagnoses of ADHD. Some of that is probably related to an increased awareness of ADHD, that it's not just a childhood problem, right? I think there's increased acknowledgement that it continues into later life. Part of it, and there's some evidence of this, some recent really interesting empirical evidence showing that later life diagnoses of ADHD are actually cases of MCI that are sort of mild, not progressing very quickly, and that MCI may actually be misattributed to ADHD. So it's a very confusing picture. And so obviously the other way of looking at this is that actual cases of ADHD that have been lifelong, but have been misidentified or unrecognized for many decades, in older adults are being misidentified as early dementia. So this is a problem for diagnostic accuracy and obviously treatment management. So this uncertainty surrounding diagnoses is reflected in feedback that we get from clinicians working with older adults. So there have been some empirical investigations into this question. Primary care practitioners say that they lack confidence in diagnosing adult ADHD in qualitative research studies that have just asked them directly, what would you do if you saw a case that you suspected had ADHD, and the answer is I wouldn't know what to do. I'm not confident. 40% of primary care practitioners say that they've never seen it in their clinic, which is surprising and is probably incorrect, because again, if you think that 1 in 30 older adults likely has ADHD, it's simply an underestimate to say that you've never encountered it, especially because, as I mentioned, people with ADHD tend to be depressed, tend to be anxious, tend to have lots of comorbid medical conditions, cardiovascular medical conditions, etc., that you'd think that in primary care, they actually would be more likely to present for health issues. So this uncertainty and discomfort in recognizing it in adults has led to quite a bit of popular coverage recently. So if you're interested in reading more about this, there have been some quite interesting articles in the Wall Street Journal, the Washington Post, the New York Times, sort of just trying to elucidate this experience in aging. And there have been specific websites and brochures aimed to increase acumen among clinicians specifically. So one interesting paper, this is one of the earliest ones, and there have been a couple since then, titled very clearly, Distinguishing Between Adult ADHD and MCI. So there is some increasing recognition that this is a thing that exists in older adults, and that it looks a lot like MCI. There's some increasing recognition of that. These articles that are sort of clinical pearls trying to lay out sort of what to look for in one, what to look for in the other, tend to focus on symptom presentation and course. As a neuropsychologist, I've been interested in clarifying which cognitive features can set the two disorders apart. And that's what I'm going to spend the next few minutes talking about. So forgetfulness is a big piece of what brings older adults to seek assessment. So just before I get into this model, I'll say that my interest in ADHD actually started at Sunnybrook where I was a postdoc fellow. The memory clinic that was associated with our research group saw so many people coming in wanting or being referred for a dementia assessment or query MCI because they were reporting memory problems. It turned out that many of those people, when you do a comprehensive history, a fair number of them ended up having ADHD. But this question of it's the memory issues that bring people to seek assessment, and that can really be the cause of a lot of confusion of like, what is it that we're looking at here? Are we looking at something neurodegenerative, or are we looking at something that's ADHD? So because of this, the issue that forgetfulness is a big piece, I sort of went into my early studies of ADHD thinking like, what is forgetfulness? And how can we understand it in the context of ADHD? And how can we understand it in the context of Alzheimer's disease? This is just a little refresher for people who have taken an introductory psychology class in undergrad. This is the Atkinson-Shiffrin model of memory. And I'm showing it here to highlight that forgetfulness actually can come from a couple of things. So for something to be remembered, it has to first be entered into sensory memory, right? You have to pay attention to it. If you're not attending to something, the unattended information is lost. So that basically just means if someone is speaking to you and you're not listening to them, you won't remember what they're saying later, right? And that so paying attention to incoming stimuli is the first step in the memory process. And then if you're paying attention, there's some aspect of maintenance rehearsal where essentially information gets encoded into long-term memory, and then it lives here until it's retrieved. So you can see quite clearly here that this first piece here, attention, this is the first piece where memory can fail. And this is what I hypothesized was happening in ADHD. So people with ADHD coming to a memory clinic saying, I'm so forgetful, I can't remember anything. I sort of thought, like, this is what's happening here, is their attentional problems are preventing them from properly encoding. Whereas conceptual models of Alzheimer's disease posit that the long-term memory storage, the hippocampus, is what is driving these memory impairments in the context of Alzheimer's disease. So people are attending to the information and they're encoding it. They just can't then retrieve those memories from the long-term storage. So to try and get at answering this question empirically, my colleagues and I looked at 40 older adults with ADHD and directly compared them to 29 same age adults with MCI. And I have a sort of a detailed breakdown of the results if anyone's interested, but just as a summary here, we administered all kinds of neuropsychological tests, memory and non-memory tests. And what we found four main things. The first thing is that on tests where people were asked to work quickly and accurately, so this is like reading words quickly off a page or copying symbols as fast as you can and accurately, both the ADHD and MCI groups were impaired relative to healthy older adults. When we gave them a story, we just read them a relatively long story and then asked them to recall details from memory. Both the groups were also impaired relative to healthy older adults. So this was interesting because it corroborated anecdotal observations that clinicians, that there's enough overlap in their clinical presentation that there's the potential to be confused, right? So this told us, this empirically confirmed the overlap between them. On another memory test where we gave individuals a structured list of words that belonged to a certain category and then gave them hints to try and remember the words after a certain delay, only people with MCI were impaired, meaning that if you provide some structure during the encoding process and then provide cues or clues that can help a person sort of revisit what was encoded, ADHD participants benefited from that. People with MCI didn't. And then the last thing that we observed that was really interesting is that on language tests, only people with MCI were impaired. So when we showed them pictures and asked them to name pictures, or when we gave them a category and said, give me as many words as you can think of that belong to this category, MCI individuals really struggled with that, and ADHD participants performed totally normally. We also did some imaging, brain imaging on these people, and we found evidence of cortical thinning in certain areas that suggest that, so frontal areas, specifically frontal areas of the brain, that corroborate that essentially. I don't need to really go into this in detail, but essentially just supported this idea that the frontal lobes that are really involved in paying attention and encoding were weaker in ADHD, and that if you support that with structure and cues, their performance can actually revert to normal. So the tentative conclusion here that we took from this study is that if you're looking simply at cognitive performance, a profile that might be suggestive of neurodegeneration rather than ADHD is people who are experiencing a retrieval deficit. So they don't really benefit from, hints or clues to try to and help them retrieve the information from their memory. They really do better with external memory aids. So, write it down, use a calendar, because your brain on its own is not is struggling a little bit to get that information out. A second unique thing about the neurodegenerative group is that they had weak word retrieval, and in everyday life, that might look like frequent word finding difficulties, for example. And then the profile that we really felt was sort of more suggestive of ADHD was this idea that the problem is at encoding here. So if you provide some scaffolding in the form of mnemonic strategies or category cues, they really seem to benefit from that. I will sort of revisit something that I said earlier at the beginning of my talk, is that a family history is also suggestive of ADHD. So again, if you're sort of wondering about this and it turns out that the patient who's complaining of these cognitive difficulties also has, you know, a brother and two sons with ADHD, that seems to be pointing in that direction. And then, of course, by definition, this is sort of what I started my talk with, is by definition, ADHD is a long-standing neurodevelopmental condition that must have been present since childhood, or at least, you know, very chronic. Now, I'm just going to take a moment to sort of speak more about this, because as I said earlier, it can be really tricky to ascertain what that looks like in older adults. So the Sunnybrook cohort that I tested as part of the research that I just showed you, when we tried to, you know, get a clear answer from these people, you know, when did your difficulties begin? Not very few of them could give us a straight answer. So some people would say, well, you know, I was disorganized in university when I first noticed. I don't really remember. I've had this issue for a while, but I've always been good at coping, maybe in my 30s. And then some people will say, oh, it's a new problem. It's a new problem within the last 5 or 10 years. And then the more you get them talking, they sort of start saying, you know, well, actually, now that I think about it, it might have been younger. And then you have actually this segment of people that say things like, I've started having real trouble managing my workload and I'm worried. I've never been particularly organized. So this suggests like potentially long-standing difficulties. But as I've gotten older, it's gotten much worse. Or people will say, I can't seem to keep track of anything. Sometimes I wonder if it could be dementia or Alzheimer's disease. And then usually if we're doing an interview with the spouse will say, oh, he's always been absent-minded. And so you think like, oh, maybe this is ADHD. But then the spouse will add like, maybe it's worse. Maybe since he retired, I can't really tell. And so that's really tricky. And so this idea that some adults with ADHD or potentially ADHD have this dual sense that aspects of their experience, of their difficulties, have been longstanding, but they also feel like there's a new component to their difficulties. There's a couple of reasons that that might be. The first reason is that it's been recognized for a few years that the intensity of ADHD symptoms, that's what you're seeing here on the Y, really depends on a pretty delicate balance between the support resources in a person's environment and the functional demands that are placed on them. So although the symptoms of ADHD must begin in early life, some kids have really supportive environments that can prevent their symptoms from being too disruptive. So for example, a person may have been very distracted or disorganized as a kid, but maybe had parents and teachers who took the role of reminding them to complete their homework and like organizing their day, right? However, as these children get older, their parents and their teachers are not around forever, right? They have fewer and fewer support resources. And at the same time, as they get older, they're increasingly expected to juggle complex roles, you know, in university, at work, within their family, in society. So there's this shift between functional demands in Black that can begin to outweigh the support resources shown in gray. So essentially put another way, symptoms of ADHD may have been present in a chronic fashion, but only maybe start to become a problem or a noticeable problem in later life. And just anecdotally, again, at the memory clinic that we saw most of these cases at, for a lot of them, retirement was the sort of thing that made everything fall apart, where they didn't have necessarily a schedule anymore or a structured work environment, and they were left sort of to organize their day completely independently, and like they really were struggling. A second reason why we may start seeing an emergence of ADHD in later life or worsening of ADHD symptoms is potentially, and like this is my second or my third take-home message, is that ADHD may be a risk factor for certain types of dementia. So this is one of the first, so this is I guess like 12 years ago now, this paper first posited this idea. Since the publication of this first paper, there's been some emerging evidence of this. So the first sort of well-designed study to look specifically at whether ADHD is associated with dementia was from 2017, right around the time I started getting interested in this question as well. And what you see here on the y-axis is a cumulative risk of dementia over an 11-year follow-up period in people with and without ADHD in red and blue, respectively. And you can very clearly see from this graph that there is a significantly increased cumulative risk of dementia over the follow-up period that's associated with ADHD. So this was the first study to look at this, the first like prospective study to look at this. And since then, about, I want to say probably 8 or 10 other studies have looked at this in different ways. And across these studies, there does seem to be a link between ADHD and different types of dementia. Interestingly, Alzheimer's disease is the least strong association. To be fair, only one study has looked specifically at Alzheimer's disease, but there seems to be stronger relationships with sort of all-cause dementia. If you just like lump all the dementias together, Lewy body diseases, specifically vascular dementia, has the strongest hazard ratio, although again, it was only investigated specifically in one study, but you can see there's a 6-fold increased hazard of vascular dementia in people with ADHD than in people without ADHD. That is huge. It's perhaps, just want to take a second to say, not surprising that ADHD may be associated with dementia, because lots of psychiatric conditions increase a person's risk for dementia. So people who are depressed have a 2-fold higher risk for dementia than people who are never depressed. Bipolar disorder is associated with a 3-fold higher risk. Schizophrenia is double the risk. Even anxiety, I recently discovered, is associated with 1.5 higher risk than people who are never anxious. And then people who are socially isolated are also at increased risk for dementia than people who are socially active. So, you know, this idea that ADHD may be one of many psychiatric conditions that can render a person's brain vulnerable to neurodegeneration later life. Now, I think the question on everybody's lips, or at least on my lips, is like, why? Why does having ADHD, or why does having any of these psychiatric issues in early life, like how does that set you up for dementia in later life? One possibility, and you know, there's many, one possibility is through the implication of vascular disease. So what I'm showing you here is a theoretical model, essentially, proposing different pathways through which depression is associated with dementia. So depression is probably the one that the psychiatric condition that's been most studied in relation to dementia. And these authors, this is an old paper now, but very relevant still, Byers and Yaffe suggested that one of the ways depression could be associated with dementia is that depression essentially increases your vascular burden through hypertension, for example, and then puts your brain at risk for frontostriatal abnormalities. Essentially, this can exacerbate brain abnormalities and render a person vulnerable to dementia. There are other pathways here, obviously, inflammation and increased glucocorticoids. I'm interested in the vascular disease part because if you think back to the first few slides of my presentation, vascular disease is significantly increased in people with dementia. So AFib, stroke, heart attack, hypertension. And I'll just say that ADHD has not been studied a whole lot in older adults from like a disease mechanism perspective, but a recent study actually that was quite elegantly designed showed that genetic risk for ADHD was directly associated with accelerated aging, specifically through some mediating factors such as smoking. They actually didn't find that body mass index was a significant contributor, but you can see that smoking, depression, and lower educational attainment, these things are associated with ADHD, and this study specifically found that ADHD increases or accelerates aging specifically through these mechanisms. So in my research group, we were interested in investigating a very similar question about whether ADHD was potentially associated with lower cognitive performance through the involvement of white matter hyperintensities. So white matter hyperintensities are shown here on this brain image. There are these white patches around the ventricles and in the deep white matter. And they can occur, they do occur actually in normal aging, but they are usually more prominent in people who have worse vascular health. So they are thought to be a brain imaging metric of vascular health, where the more of these white matter hyperintensities you see on imaging, the worse vascular health this person's brain has, meaning that their blood flow, the blood supply to the brain is not optimal. So we hypothesized, similar to this previous study that I showed, we hypothesized that ADHD would be related to cognitive aging because it increases your vascular disease burden. So what we found here, I was very excited about these results. What we found here, and just to clarify what it is that we hypothesized, we thought ADHD would be associated with more white matter hyperintensities, worse vascular health, and that would explain their cognitive performance. What we actually found is that participants with ADHD, in purple here, actually had significantly fewer white matter hyperintensities across the whole brain, near the ventricles, and in their deep white matter. And I was very surprised. I actually ran these analyses like 6 different times, thinking I must have made some mistake, because when you looked at their cognitive performance, the ADHD participants were not doing very well. They were experiencing the attentional difficulties that I talked about earlier. They were experiencing specific types of memory problems that I talked about earlier. And so it was confusing to interpret like why are they doing poorly cognitively speaking if actually their brains are relatively healthier from a vascular standpoint than controls. Instead of, so essentially we switched our way of thinking, is maybe ADHD status is not impacting cognitive performance because of white matter hyperintensities. Maybe a small amount of white matter hyperintensities in ADHD has a stronger effect than it does in healthy aging. And so we investigated that alternative hypothesis. And that's exactly what we found. So I'm just showing you results from a memory test now, but we found this across many different metrics. On the y-axis, I'm showing you average cognitive performance. So higher is better, lower is worse. And on the horizontal x-axis, you're seeing essentially a metric of the amount of white matter hyperintensities in the brain. And what this is showing is that for the same amount of white matter hyperintensities, so let's say 1.5 this is a log transformed measure, so it doesn't really mean anything, but let's say 1.5 units of white matter hyperintensities in a healthy control is not really having any impact. Whereas in ADHD, it's having a very significant impact. So the same amount of brain pathology is having much worse of an impact in ADHD from a cognitive standpoint. And this actually dovetailed so beautifully with another study that came out the same year, looking at the same question. So whether, well, they used ADHD like genetic risk, but essentially the same question is, does ADHD genetic risk, what is the relationship like with amyloid beta deposition? So they, instead of looking at vascular health, were looking at markers of Alzheimer's disease. And they found exactly the same thing as we did, that for a given, actually the figure is a little bit different. Over time, that's what's on the x-axis here. Over time, people significantly decline cognitively if they have ADHD or an ADHD genetic risk and amyloid beta. People who have just amyloid beta or just ADHD are actually doing fine. So it seems to be this idea that a given amount of brain pathology, whether it's vascular pathology, which is what we looked at, or Alzheimer's pathology, which is what this study looked at, having an amount of it in your brain will impact you more if you have ADHD, is what we're taking away from these findings. So something about having ADHD renders the brain vulnerable to even low amounts of brain pathology. So I just am going to close my talk here with this visual, which many of you may have seen. It's from a 2020 Lancet Commission paper outlining early life, midlife, and later life risk factors for dementia. This paper identified 11 different risk factors that, if eliminated, would significantly reduce dementia incidence by the percent indicated in each of these bubbles. So for example, eliminating depression is hypothesized to reduce population dementia incidence by 4%. I am excited to be doing research that suggests that ADHD may be another potential early and midlife risk factor that's worth monitoring, potentially to impact later life cognitive aging, but also just becoming more aware of it and monitoring it, because I hope to have convinced you that it can at least mimic dementia, and that has important implications for assessment and management. So with that, I'm going to end my presentation, and I'm happy to take time to chat if there are questions in the Q&A.
Thanks so much, Brandy. So as you just heard, please use the chat box or Q&A to ask any questions. So one question has come up. In your research, have you found any correlation between chronic and severe insomnia with non-ADHD or ADHD and risk of developing dementia? It is my understanding that the other risk factors you mentioned, example, anxiety and depression, are also typically related to insomnia.
Yeah, that's a fantastic point. And it's hard to disentangle, right? These things often go together. So depression and anxiety are often comorbid. Anxiety and sleep disturbances are often comorbid. I have not personally looked at sleep in my own research, but I think it's quite well known among healthcare professionals that sleep is something that can significantly impact cognitive performance, and chronic sleep problems can impact how a person ages cognitively. I think we need to also be careful about what kind of sleep problems we're talking about. There are some that are more clear risk factors for dementia, like sleep apnea is one. And like mechanistically, that one is easier to, it's a little bit more straightforward because you think, well, if the brain is not getting oxygen while you're sleeping, that's a direct physiological risk factor for the health of the brain. But yeah, for sure, I think it's tricky to tease apart these individual mechanisms.
So a couple questions coming through the chat box. First is Dr. Grief saying, thank you for that wonderful talk. I recall you had mentioned in a previous talk about increased risk for DLB. What is the latest thinking on this linkage?
Yes, thank you, Dr. Grief, for bringing that up. And yes, there does seem to be, so DLB, Lewy body diseases, this includes Parkinson's disease and Lewy body dementia. Those are the ones that in studies teasing apart different types of dementia, that's the one that sort of emerges more or less consistently. I hesitate to, I don't know what my opinion, I don't have a strong opinion about it because most studies don't pick apart different types of dementias. Most studies just look at all-cause dementia. And the 2 or 3 studies that I'm aware of looking specifically at DLB were designed in a way that there may have been some sampling bias there, that they were really looking for things specifically associated with DLB. So I don't actually, I'm sort of, my thinking about that is flip-flopping, but actually just last week, I think there was a new paper out of Brazil. The lead author's name was Angel Golemstock. If you want to look up that paper, it was just published a few days ago, looking specifically at relationships between ADHD and DLB.
Thanks, Brandy. Another question came through from Irina. What non-pharmacological interventions would you suggest for clients with ADHD and moderate to severe dementia? One of our BSO RN educators, our only RN educator for BSO.
Yeah, ADHD and moderate to severe dementia. So that's interesting because yeah, I think like as I said at the end of the talk, you can have both ADHD and dementia. I think once the dementia sort of kicks in, I think external memory supports are probably your best bet. So yeah, I guess in the severe dementia stages, I guess those may be limited, but things like external memory aids, you know, alarm reminders, calendars, things like that. In a case where a person only had ADHD, psychoeducation and like co-developing like mnemonic strategies tends to be quite helpful. Although interestingly, I'm now involved in a study partnered with a place here in Calgary that specifically gives services to to adults with ADHD. And we're finding that older adults who go through that program tend not to benefit as much from as the younger adults. So I hesitate to even sort of recommend for older adults what's currently being offered to younger adults. But sorry, long-winded answer to your question. My answer probably would be to rely on external memory supports like calendars, lists, reminders, alerts, things like that.
Great. So Gita asks, first she comments saying, thank you so much for this great presentation. And she asks, have you found any nursing care planning sample for older adults with ADHD?
I have not. There have been a few very good, actually, recent papers, review papers, just commenting on the management of ADHD in older adults specifically. I'm happy to I think there's like 2 or 3 that I could put together and I can share them with Kara if you want to, I don't know if you have a way to circulate them afterwards. But yeah, I can share those.
And Shelley says, first, thank you for a wonderfully clear and informative presentation, and asks, has there been any research that looks at treatment of ADHD and or mood disturbances and whether that attenuates the impact or association of ADHD and dementia?
Great question. The first thing is that stimulant medication can sometimes be tricky for older adults with ADHD because although it's very effective from a cognitive standpoint, one of the main side effects is hypertension. And so in older adults who are already hypertensive, or maybe there's some issues with polypharmacy, that can be a little bit tricky. I'm aware of 2 studies that have specifically looked at the relationship between medicated and unmedicated adults with ADHD and their dementia risk. One study found that dementia risk is actually attenuated with medication. So people who have ADHD who are medicated actually tend to have lower dementia risk. And the other study found the opposite, that people who are medicated had higher dementia risk. So unclear take-home message from those conflicting papers. But I think it's something that people are definitely interested in. It's something I get asked a lot about when I give talks about ADHD, is like, what's the role of medication? So I expect we're going to see a lot more of that research in the next few years.
And I have a question, Brandy. So when it comes to ADHD and dementia, what are the typical responsive behaviors you might see? I would suspect restlessness or just like pacing and that sort of thing. Are there any other responsive behaviors that come to mind for this population?
Yeah, I probably would expect, and actually this is just speculation because I don't think there's been any empirical investigation into this. My guess would be probably an exacerbation of some of the pre-existing sort of frontal behaviors. So the impulsive behaviors, the restless behaviors, because again, ADHD being sort of a frontal weakness is the frontal lobes are less able to sort of regulate behaviors. So sort of more dysregulation, more emotional dysregulation is not something that I spoke about, but is very common in adult ADHD. So that's probably what I would expect in terms of responsive behaviors: emotional dysregulation, impulsive behaviors, socially potentially inappropriate behaviors, and restlessness.
Thank you. Any other questions from the group? We have about 4 minutes left. Feel free to, again, use the chat box or Q&A. And Shelley says, thanks again. Is it fair to say that the increased risk for dementia is largely mediated by the impact of associated conditions?
Fantastic question. That's something I am heavily invested in studying in my own research. One of the things we're looking at is these vascular conditions, but you're right that, I opened my talk saying that ADHD is associated with sleep disturbances, and I didn't mention this, but traumatic brain injury, very common in ADHD, all kinds of associated medical conditions. The last 2 or 3 large population studies that have looked at ADHD and dementia risk factors actually controlled for a lot of these things. So there's a paper that just came out probably about 4 months ago, and they actually looked at that association and accounted for traumatic brain injury, depression, stroke, heart attack. And they actually found that the association between ADHD gets a little bit weaker, but still remains. So the best evidence we have now suggests that even if you remove the contributions or the mediating impact of these associated conditions, there still seems to be a considerable contribution that's unique from ADHD.
Shelley adds, if so, then can we hope that treating these, we may again potentially mediate the risk?
Yeah. I mean, I think in a person who has ADHD and other medical conditions, it's probably always a good idea to treat the other medical conditions, but yeah.
Wonderful. So we're almost at time. Maybe one more quick question, if there are any. And Shelley said, yeah, you answer that. Perfect. Okay, so maybe we'll wrap up. Again, a big thank you from myself and from everybody today for you, Brandy, and this really, really informative session today. There's some comments in the chat box coming through to thank you as well. Just a quick reminder that if you'd like a certificate of attendance, please complete the brief evaluation survey, which will be emailed to you. The recording will be available on the Ontario CLRI and the BSO websites. Thank you again to everyone for joining us, and have a wonderful rest of your day.
Thanks so much for having me.
Thanks, Brandy.
See
Take
ya.
care.